Dr. Sengul Ozdek will speak about bilateral falciform retinal folds.
Thank you for the invitation, and I'm happy to be here with you. I think my case will be a kind of answer for your question. So this was a bilateral tractional retinal detachment case which falciform folds, which we think it's a fever case. This was a 2-month-old baby girl with term birth, no prematurity, referred with the diagnosis of retinal detachment. And you see the right eye had closed funnel retinal detachment with almost leukocoria, and the other eye, left eye, has a retinal fold, but it was attached to the back of the lens with some hemorrhagic membrane. And this was the fluorescein angiography of the right eye. You see the peripheral avascular retina and associated in the border, associated neovascularizations, and of course the capillary non-perfusion. And this is the fellow eye with again peripheral avascular retina and neovascularization in the border with some fibrovascular tissue. So in the differentials, we should of course think of prematurity if there's prematurity history. And for fever, we should check the family history, and we should do the family screening, and we should check the skin problems if there's any skin rash for incontinentia pigmenti, because it was a baby girl. And if it was a male, maybe we should think about nori disease. And now we think that it's fever. Although there's no family history, 50% of them don't have any family history. So this was the surgery for the right eye. We were not expecting much from the right eye, but we just wanted to, attached a little if possible, and we could do a lens sparing vitrectomy, as you see, and we just peel membranes as much as we can. You don't have to peel all the membranes, and you can't, of course, also. And we try to relieve the retina as much as we can, and then leave the eye in air and just let the retina go down backwards. And this is post of 1 year. You see retina is much backwards, although we couldn't open up the funnel totally. It's much backwards. It doesn't cause leukocoria, and better. Of course, our main aim was to treat the left eye. And you see it was attached to the back of the lens with that hemorrhagic membrane. After cutting that membrane, which may be kind of PFV, I don't know, Supadra, I don't know what you say, but kind of PFV stalk connecting to the back of the lens. Then we try to peel the posterior hyaloid and to relax the retina. And of course, when you cut the connection between the lens and the retina, it will relieve the traction to some extent. But while doing that, I had a small piece of fovea in the membrane. So I thought that it would be a macular hole. Then I was not planning to peel everything, but now I have to do more peeling because I have a suspicious macular hole thing. That's why now I'm peeling more and more. I have already detached the posterior hyaloid, and now I'm dealing with the membranes. Sometimes it's possible to unfold that falciform retinal folds, like in this case. So, of course, you have to be careful. You shouldn't risk having a retinal break, but you should peel as much as you can. And then again, I left the eye in air, did the laser to the peripheral avascular retina, and this was the 1-year result. I put silicone oil because I have some macular hole thing, similar to macular hole, but after silicone oil removal, the fold was totally unfolded, retina was attached, and you can see the OCT pictures, right eye in the upper side before and after, left eye before and after. So may I have the last slide, please? So my take-home message in such cases is we can do bilateral immediate sequential with retinal surgeries in such small babies. Instead of giving twice anesthesia, we should try to spare the lens if possible, relieve as much as the membranes as much as possible without causing a break. And I would like to invite you all to EVRS meeting in 10 days in Cancun, Mexico, and to the 4th ROP course next year in Istanbul. Thank you.
English. Thank you very much. Any comment? Yes, Gata.
Thank you for this nice presentation. Two questions back. Do you use mitomycin to avoid those cases? And do you use PFCL as a template? How much time you need?
Okay, so I don't use mitomycin C if I don't have any retinal break. So if I have rhegmatogenous retinal detachment dealing with like Stickler's cases or ROP sequelae having rhegmatogenous retinal detachment in later life. So in those cases, I always use intraoperative mitomycin C. And if you like, I can explain my technique. Yes, I put it into the posterior pole only and do air fluid exchange. I leave the PFCL at the posterior pole and do air fluid exchange and give the brilliant blue stained mitomycin C into the area where I want to expose. So I protect the lens and ciliary body with air and the optic nerve and the macula with PFCL. So in between, like a sandwich, I put the mitomycin C for 1 minute and rinse it totally. But I do it only for the rhegmatogenous retinal detachments. And for, I don't use PFCL as a, temporary tamponade. I didn't try it. Yeah, I use always air if I don't have any retinal break. Just air is enough. So if you don't have any retinal break, retina will go down, settle down itself. You don't need any tamponade, any other tamponade.
Yeah.
Actually, if you see the babies in the NICU, they're always fed. That's how they are fed, that's how they are, so taste. In the NICU, babies are always kept flown after feeding, use work, and then put them upside down. So normally when we put air, we don't put them straight because they can get cataract. So for 24 hours, the parents can keep them on the lap or on the shoulder.
Yes.
Like a kangaroo mother care, they can be this now. Then they are toddlers, they can
Yeah, Dr. Osama.
Thank you for the excellent presentation. You talked with Dr. Jalali about the combined hamartoma of the retina and retinal pigment epithelium. I'm asking you about long-term visual expectation, those cases who have actually disorganized retinal tissue.
What's the expectation if we have?
Long-term expectation for cases of combined hamartoma of the retina and retinal pigment epithelium. Those cases in particular having disorganized retinal tissue. What about long-term expectation you experience?
Actually, we made a study on that, multi-center international study, and we have published the data. Maybe you can check, because in these cases we could have amblyopia. So that's the reason everybody is asking, should we do surgery? It's already amblyopic, but we have shown that if you don't do the surgery, the lesion grows within time, most of them. And when you do the surgery, it becomes smaller. That's the first thing. And you start, of course, if they didn't do it before, you start the amblyopia treatment, and that may also help. But you can question if you can do only the amblyopia treatment instead of doing surgery. And we compared our data, and surgery group did better in visual results.
Thank you so much.
Thank you.
Yeah, Dr. Sheng, the last question. At what age you can say this is too late to unfold?
Actually, it depends on the underlying disease. For example, in ROP, it may be. I have operated cases like I have presented, just last hour, 1 hour before. I have operated cases at 4 years old, for sometimes, who have leukocoria, but the retina is not closed funnel. But there are some tractions, but you don't see it. It's totally leucocoric, but has hand motion movements. So I do the operation, and he starts to see 20/400. Sometimes this happens. But normally, we don't want to do it that late. So it depends on the underlying disease. For example, fever. If it didn't start from the babyhood, but it started to become folded later, then you can do the surgery, of course, in the later ages too. But it depends on the duration of the disease also.
Okay, with the introduction with the micro cannulas where you can inject in the subretinal spaces, for instance, you think this might help?
we have some, retinal folds, which is attached to the back of the lens. I don't, of course, go with the vitrector, but I go with the scissors. If I can find a space in between the membrane and the lens, I go with the scissors to cut the connection. And then when it goes backwards, I do the vitrectomy afterwards. And for the previous question, it depends on the traction, the side of the traction. If it is anteroposterior, you can do it anytime, if you see it. So it's easy to cut and it's easy to relieve. But if it's a tangential traction where you can't find any place to dissect, then you don't want to touch it. Thank you.
Thank you very much.